Prof for the detailed introduction on cure and epilepsy. We have now reached the most awaited moment of this seminar, the presentation by our keynote speaker. As the leading expert in epilepsy research, Professor Ley Sander barely needs any introduction. He has more than 650 publications to his name, with more than 32,500 citations, a H factor of 96, and still counting. He's a man on a mission. While studying in his native Brazil, he also worked as a paramedic answering emergency calls to make ends meet. In one of his first outings, he was sent to a public square to help a woman who was demanding diazepam because she was about to have a seizure. This episode that ensued, and after witnessing her seizure, which was the first seizure that he had completely witnessed, convinced him that his calling was in neurology, specializing in epilepsy. His commitment to epilepsy research is reflected in his notable quote, "Just reducing a person's seizure is not enough. We must aim for complete seizure freedom for everyone. This is our holy grail. We want to cure epilepsy, not just control it." He wears many hats, many of which have a global impact. He heads the World Health Organization Collaborative Center for Research and Training in Neurosciences and is a member of the editorial board of the Lancet Neurology. He has been recognized with many prestigious awards, amongst which are the International League Against Epilepsy and International Bureau for Epilepsy, Ambassador for Epilepsy Award, and the Research Recognition Award for Clinical Sciences of the American Epilepsy Society. Ladies and gentlemen, please join me in giving a warm welcome to Professor Ley Sander, Professor of Neurology at University College London, Institute of Neurology, and Consultant Neurologist and Clinical Lead for Epilepsy at the National Hospital for Neurology and Neurosurgery, Queen's Square, London. Prof. Sander will be speaking on preventing SUDEP and how to build research around SUDEP.
Thank you very much for the invitation to be here. It's always a pleasure to be around this area of the world. The opportunity to come to Malaysia and to talk about epilepsy and to talk about one of my main research interests is always something that I look forward. I would like to tell you today something. Can you not hear? I would like to tell you a little bit today about something that that was already alluded here by the previous speaker, which is SUDEP. The way I want to do it is to discuss ways that SUDEP, and I will come to try and define what it is, we could have initiated research and how we could have tried to look at this picture. I think that we already heard here that epilepsy is often say, well, someone has a seizure and that's it. But it's actually not a benign condition. It's really a very malignant condition that kills a lot of people. And for people with chronic epilepsy, this one, SUDEP, is a major problem. So I will try and cover a number of aspects of SUDEP and try to see how we could have started research, how we could have gone along trying to understand this. I will cover very briefly some of the historical aspects. When it was found out and how did we come up with the understanding that this is one of the worst outcomes that we have in epilepsy. I will mention the issue that is very important for us to understand. This is the premature mortality of epilepsy. And you need to put SUDEP into this context. So you can actually only see a problem if you can see the context. I think it's very important that we remember that for researchers, we often work in very small areas but we need to see things in the context. Otherwise, we go back to this story of the 5 wise men that were researching an elephant blindly. Each one had a blind, and one would actually be examining the legs and would actually touch and see how the legs were. Someone could be doing this at the tail, one at the trunk, and one at the body. And when they get together, everyone will give a very completely different picture of an elephant. It's only if you see the elephant in the context, you will understand what the legs, what the tail, or the trunk mean. So it's very important that we always place whatever we want to investigate, research into the context. And here, the context is the premature mortality of epilepsy. I think it's important that when we speak about mortality, we do put it in the context. So it's premature because everyone will die. So mortality is an outcome that we will all have to face. What makes different the condition if someone dies before their time, so prematurely. We need to discuss the causes of death. You know, why do people die? And what makes epilepsy different from other conditions? We then will very briefly try and tell you a little bit about the definition of SUDEP and how we came to this. And this involved quite a lot of research to try to understand why we would come up with a specific definition. We'll talk about possible mechanisms. And I think it's very important to say possible, because SUDEP is not yet something we fully understand. And this is why CURE is so interested, because they want to find out why someone has SUDEP, so something can be done to prevent it, to avoid this outcome. So people will die when their time comes, rather than die prematurely. We're going to talk about some of the risk factors. And I think it's very important that we understand the risk factors, because that will give us subsidies to try to work on mechanisms and what actually trigger things. And at the end, just a few words about possible preventions and what do we know at the moment. Well, epilepsy is not a benign condition. We heard this today. We also heard that the mortality in epilepsy is 3 times higher than you would expect for people of the same age in the population. This is what we call the standardized mortality ratios. However, I suspect that this is really an under-reporting, that this number is probably much higher. And I will come back to this later. We have this big paradigm, we have this sort of paradox in epilepsy, because we have an incidence, and you've seen some of the graphs, quite high. But you know, if we look at the prevalence, it's much lower than you would expect for such an incidence. So there must be an explanation. We as doctors often like to think it's our medicines, but we also hear today already from Farouk that most people with epilepsy worldwide and from the WHO video are not treated. So something else is happening. And the probable explanation for this discrepancy between incidence and prevalence is premature mortality. Now, we have, for instance, some groups in developed world, in the sort of high income economies, that we know at higher risk. For instance, people between 20 and 40. Well, that's not a surprise, because people between 20 and 40 are usually the ones that are less likely to die in the community. And that throws up the numbers. But if they have chronic epilepsy, it's probably even higher. And this recurrent evidence coming, it's sort of circumstantial, but it's always going in the same direction. It's much greater mortality of epilepsy in resource-poor settings. And I don't think that this is really real. I think that what we have in the developed world is an under-reporting. So the numbers probably are similar, but we have this under-reporting. For instance, There's data from rural China showing that epilepsy has a standardized mortality ratio which is well in excess of 20. So people with epilepsy are 20 times more likely to die than their peers in the community. We have similar data from Kenya, we have data from Georgia, the former Soviet Union. And they all point in the same direction. The mortality, premature mortality, is a big issue. And this is just to show you, this is a slide trying to, yeah. This slide basically shows standardized mortality. Well, if you have a standardized mortality ratio of 1, you are the same as the general population. That's what. If you have a standardized mortality ratio that is below 1, that basically means you're protected from dying from what we're discussing. And if it's above 1, that means that, for instance, 2, basically it's double that of what you would expect for someone from the same age and the same gender. And you know, the higher it goes, the higher is the mortality. This is from cohorts in the UK, where we looked at a number of people over the years, and you can see that anything that is above this line of 1 is a significant increased mortality. So basically we have an initial big mortality. It sort of goes down and then starts to slowly go up again. And the longer you follow up, you will see that people are dying earlier, and you can say that if someone has focal epilepsy, partial epilepsy, this is taking up to 20 years off your life expectancy. That might explain why we don't see more elderly people with epilepsy in our clinics. Now, I mentioned this epidemiological paradox, and I think that's very important that we take this on board, because this is part of the context. This probably means that we should be more active and more trying to identify people with epilepsy and be able to offer treatment, because the treatment gap is a big problem. And although there has not been a study that is specifically followed up people not treated, because that would not be ethical, you can make inferences from the findings of a number of studies that, independent of where you are, the prevalence is usually no more than, let's say, between 0.4 and 1%. But the incidence is much higher. So there's something that is playing here, something. Now, just to try it to go over this. This is the prevalence of active epilepsy in a population, and this is from Rochester in Minnesota. This is the cumulative incidence or lifetime prevalence. This is anyone that ever had epilepsy. And this is the incidence. We see it's higher in the first year of life. It goes down and then starts to go up. This is from 20 years ago. And if we were to look at the similar graph from recent days, we will see that this incidence is much higher now, because the group in the population with the highest incidence are the senior members of our population, because the older people get, the highest the risk. So the difference between the cumulative incidence and the prevalence, we hope, what we think, or we might be basically deceiving ourselves to think it's only the drugs and only the treatment. It's more likely that this gap is because people are dying earlier. And there's a lot of circumstantial evidence to come to show that. Now this is a graph of people from rural West China, people that had treated epilepsy. And if you remember that the standardized mortality ratios of 20, they mean that people are 20 times more likely to die than their peers. You will see that young people might have SMRs over 40. This is staggering high mortality. And this probably explains this paradox. And this has been seen in other parts of China, and this was very instrumental in China to let the Chinese government to bring out a national epilepsy program, because they could identify a large number of preventable deaths from this. And this is slightly different. This is now a logarithm scale, And again, what we see here is that, and this is from 8 provinces in China, from the National Epilepsy Program, that people with epilepsy mortality is much higher. And this is from rural Kenya, again for convulsive seizures. And there's quite a lot of people lost to follow up. This is why there is low confidence intervals. But I think it's very clear to see that this is still well over 10, despite all the losing people in the cohorts. That still shows things going in the same direction. So we know that epilepsy, premature mortality is a big problem. But and this is now the next question we have, and we need to try to understand what is actually killing people that have epilepsy. So of course, someone has epilepsy, they could die from a cause that is completely unrelated to epilepsy. You might be walking in the street and a plane door falls on your head. Not that this happens every day, but that would be no ways why this door will hit you because you had epilepsy. That's just random. So people may die from causes completely unrelated. But they may also die from whatever is causing the epilepsy in the first place. For instance, a degenerative disease, people with cerebrovascular disease, or a brain infection. So this could actually kill people. But people can also die as a result of epilepsy, and that's where SUDEP comes in. And now, for instance, someone may die as a result of the treatment for epilepsy. For instance, a drug that causes an idiosyncratic skin rash that can then progress to, let's say, a Steve Johnson type syndrome. The person may die. Someone may have epilepsy surgery and something goes wrong and the person may die. So people may die as a result of treatment. But this is, praise the Lord, this is a very small number. The majority of the time, okay. Promise not to shout again. So, most of the time, when people die due or related to epilepsy, it's going to be the condition itself. And we will come back to this. So, people may die as a result of the same condition that is causing the epilepsy, and this accounts for this initial mortality. Indeed, if someone has epilepsy in the community, through the ages, 20% of these people will be dead within the next 5 years. So this is the first thing that we can say. And in these first years, the underlying disease, be it the cerebrovascular, degenerative, whatever is causing it, will be responsible for death. And in this group, SUDEP is relatively rare. SUDEP will start to kick in some years later. Now, if we have a question that is coming out, is that people that even when epilepsy is completely cured or has gone away by spontaneous remission or by treatment, people still have a higher mortality. So this is likely to be explained by comorbidities. And comorbidities are a problem. We have some specific comorbidities in epilepsy. And if anyone is around tomorrow, I'm going to discuss this tomorrow, the Sir John Monash lecture, what the role of comorbidities have in mortality. And there's some interesting clusterings of comorbidities, and they might be telling us something. And this is an important question. Now, this is the causes of death and an incident cohort. And I think it's very important that we always, as researchers, we need to understand the difference about something on a prevalence cohort and something in an incident cohort. I think that an incident cohort is always the purest way that you can actually get something done, or you look, or you're getting proper numbers, proper data. Because in a prevalence cohort, that is, you get people that already have a condition, you will have people that have started their career, their condition at different times. And some of these people may already have died. So the best way of you looking at this is you follow up an incident cohort. This is everyone that started at a specific time, you have the same starting point. So you can look over time what happened. And then this is clearly showing that in the initial years, the 10 years of life of people, the majority of people will die from comorbidities, and only a very small number of people earlier on will die of epilepsy-related death. For instance, SUDEP accidents as a result of epilepsy. The numbers are very small. And what you basically see is the role of the comorbidities, the same condition that causes the epilepsy. Now we're moving on from people with newly diagnosed epilepsy. Let's say you survive the first 5 years. And what happens then? Well, this is when epilepsy mortality due to epilepsy starts to kick in. And we know, for instance, that people with epilepsy, they have an increased risk of suicide. And there might be some interesting reasons for this. There might be some interesting comorbidities. And indeed, having survived an attempted suicide is one of the biggest predictors that someone will develop epilepsy in the next 3 or 4 years, even if you control for brain damage. So this is probably telling us something. Like, one of the biggest prognostic risk factors for epilepsy is having had a clinical significant episode of depression. This really seems to increase the risk of developing epilepsy 6 to 11 times. And this has been replicated in a number of studies. So now, what does this tell us? We need to work it out. So trying to understand this as a potential risk factor of epilepsy, and what the commonality of these two things could be telling us something about a puzzle. And of course we have the seizure-related death. And they come in a few forms. For instance, if you have a seizure at the wrong place, at the wrong time, you could come to harm. For instance, if you're crossing a road and you have a seizure and a car cannot stop, you might be hit. And was it, of course it was an accident, but the accident happened because you were not in control, you were not aware, and you were hit. People with epilepsy, for instance, have a high risk of drowning. And indeed, the latest meta-analysis suggests that people that have epilepsy are 20 times more likely to drown than their peers in the community. And this might be, of course, dependent if you have water bodies near to you. In parts of Borneo, people have a seizure, they live in houses, they fall in the water, you can understand that. But in places like the UK, where the personal hygiene involves jumping in a puddle of dirty water called the bath tube, between 80 and 110 people drown every year, most of them due to seizures. And we had a lady from Bollywood star that drowned in her bath. And it really made me think, hey, did she have a seizure or something? She might have had something else. But the great majority of people that drown in the bath, they die because of epilepsy, about 90%. So I think that is something that we always try to convince my British patients that they should adopt a different way of personal hygiene. Because, jumping in a puddle of dirty water might have other risks apart from not being good for your skin. Of course, people may have, we all know about status epilepticus. This is when a seizure leads to another seizure, or a seizure becomes continued over time. And this will lead to brain damage, can lead to multi-organ failure, and eventually could die. But thankfully, this is coming down, and in most places, the people with epilepsy, they tend to have nowadays less status. The commonest trigger for status is people stopping their medication. So often just replacing the medication will bring down this risk. Now, just to reinforce the suicide, meeting has, okay, we promise not to be idle. Now, the latest meta-analysis shows that people with epilepsy are 3.3 times more likely to commit suicide. But there's a clear difference between people. For instance, you might be cured by epilepsy surgery for your temporal lobe epilepsy, but that doesn't take away your risk of suicide. Actually, in this group, it could be 11 times higher, and there's good data to support that. people with epilepsy have accidents, and indeed, there's a large European study of thousands of patients where they actually looked at the number of seizure-related injury required medical intervention in people that have active epilepsy. More than 30% of people would have had an injury that would require medical intervention. So you could argue that if this over time, this could lead to some, over-inflammatory reaction. It could lead to a number of things. I mentioned this already, but it's very important that we remember, and this is something very new that's coming up, and it's already been circumstantial evidence to confirm this. Even if you have well-controlled epilepsy or epilepsy that's gone, your mortality still increases. And indeed, if you have had a diagnosis of epilepsy 25 years ago, you're 2.3 more likely to die than your peers in the community. This is the life expectancy that is decreased. And this is something we do not fully understand, but there must be a role for the comorbidities. We know, for instance, that people with epilepsy of a specific type are more at risk of diabetes type 1. Some types of epilepsy seem to increase the risk of diabetes type 2, or vice versa, because this correlation seems to be bidirectional. This is likely to be telling us something. I think that we need to remember that in the context, premature mortality is responsible for a good part of societal burden as a result of epilepsy. It plays a role in this good prognosis because we assume people are doing well just because they don't come back to the clinic. They might not be able to come back to see the doctor because they're not around anymore. So I think that this is something we need to keep in mind. But most studies that we have, they clearly indicate that we have a staggering high mortality, premature mortality, and SUDEP is a major player in chronic epilepsy. Once you have gone 5 years having a career of epilepsy, after 5 years, the risk of SUDEP seems to kick in and goes on and on. Now, I mentioned that when you want to do research, one of the first things you need to do is find out what people know. When was this first identified? So when the SUDEP came up, and I got interested in SUDEP, my main interest is outcomes. So outcomes of drug treatment, of surgical treatment, of epilepsy in the community. I consider myself an epidemiologist. I'm interested in the dynamics of a condition, in my case epilepsy. And thank you for reminding me of my ambulance time, which was an interesting time when I was a paramedic. And that's how I really got interested in epilepsy. But, if you have suddenly a condition and you say, hey, what's going on? You need to ask yourself, when did this start? Who did it affect it? When? And because you then may get the answer to why. When this interest in SUDEP started around the late 70s, the first question that came up, is it the drugs? And indeed, there was quite a lot of debate at the time. Could it be different drugs? There was the issue that carbamazepine sometimes can cause very mild arrhythmias. Was this playing a role? But then when people started to look back, it was very clear a lot of historical literature on SUDEP. Indeed, in the 1860s, the Lancet, the medical journal in London, had an editorial describing the way that people with epilepsy died, and that was a description of SUDEP. There were a number of studies in the late 1800s, in the early 1900s, but suddenly there was a complete loss of interest in SUDEP around the 1920s. What happened in the 1920s? This is when phenobarbital came along after World War I. And actually, phenobarbital was a German drug that was given to the Americans as a compensation for World War I. And then it came out as luminal. It was actually an American drug. But that drug made a major difference to the point that many institutions for epileptics in Europe and in the States, they closed the door because the number of patients fell by, there were reports of 70% of people becoming seizure-free, 50-60%. So it made a big difference, and it seems that at that time doctors thought, oh, we have sorted the problem, we're not going to be concerned about mortality. And things only rekindled in the 1970s when the coroner for Cook County, where Chicago is, suddenly where Cure comes from, he was really surprised by seeing all these epileptic patients. And first he thought this must be drugs, recreational drugs, and then the drugs for epilepsy. And that's how this was sort of resurrected the interest in SUDEP. And then it sort of started, but this left the impression that SUDEP was something new. It was only when people started to look back saying, hey, SUDEP was there a long time before the modern drugs. And it's probably unrelated to drugs, but we still have to prove it. So historically, we have seen SUDEP for a long time, and there are long old descriptions about that. The definition is that this is a sudden, unexpected, unwitnessed, non-traumatic, non-status epilepticus death in someone who was well and had epilepsy. And this is an important point for whom in a post-mortem you don't find an anatomical or a toxicological reason for death. And this creates a problem because this definition requires post-mortem examination. And in many cultures and many places this is not very easy. So often, you cannot actually assign a diagnosis because you don't have the full. So there have been some modifications. For instance, if everything fits in, if foul play has been put aside, you could probably still call it a probable or a possible SUDEP, because we cannot always get 100% diagnosis because of the requirement for post-mortem. There is a clear gradient towards severity. So the more severe the group of patients you're looking at, the more SUDEP you will see. So there is one study that looked into withdrawal of antiepileptic drugs among a large cohort of people with epilepsy. There it was 1 in 2,500. But if they were coming off drugs, means they were seizure-free. If you control this for the population, you would see that basically the population rate of sudden death was about 1 in 4,800. That would be the equivalent. So you can see that it was even amongst people with not with controlled epilepsy, there was a slightly higher risk than you would expect. And this goes up. So in terms of if you are an attendee of my clinic at the National Hospital, there is a 1 in 200 every year of someone dying. So I see 1,300 patients on average. You can see I every year lose a few patients. And we like to think that we provide good care. So this is really an issue. And indeed, I got interested in SUDEP once I was doing tourist guide sort of duties in London. And I met the brother of one of my patients who I had not seen for a while. And I said, oh, Mr. X, he said, so you don't know, he passed away. He didn't wake up. And for me, that was a wake-up call. Because I went back straight to the hospital, identified people that had not come back to the clinic, wrote a letter to their GPs. And this was when Lena Nashkev joined me, because she was the fellow that we were doing this. And I found out that of 24 patients that had not attended my clinic in the previous year, 5 had died. So for me, it was a big eye-opener, and that's how my interest in SUDEP started. So if you're rejected for epilepsy surgery, there's a 1 in 75 chance of you dying every year. You don't have to be a mathematician how this builds up over the years and how much attrition this will cause. There's an interesting study from the Mayo Clinic which shows that a young person with epilepsy is 24 times more likely to die suddenly than the peers in the community. And we have estimated in the UK, just by reading clippings of newspapers and by doing what was called a sentinel audit, we identified that every year there are between 600 and 700 definite cases of SUDEP, and probably another 300, 400 possible cases. So you don't have to be very smart to do this research. You just set up a Google News alert to looking at sudden death amongst epilepsy and the coroner's report, and you will see that this happens. And you know, you could get a basic number of this in several. We've done this in different countries, and we get always a similar picture. Pathological finding, well, you could have no findings, but there might be some non-specific findings, often indicated they might have been a seizure. And what we can say is that no pathognomic neuropathological lesion identified to explain SUDEP. This is why it's called sudden, unexpected, unexplained death. No, the other way. Now, you will see in a minute that the major risk factor for SUDEP seems to be convulsions. And then, you know, it's very important for us to try to understand what happened to a person at the time of a convulsion. This is really a perfect physiological storm. So quite a lot of things happen. You have really a burst of blood pressure. The blood pressure goes sky high. There's an increase in the venous pressure and the cerebral venous pressure. The arterial gases just change around. There's a release of hormones. You have hemoconstipation, hyperkalemia. So there's quite a lot of physiological changes. And if you have this every so often, and you have sort of, you know, boats of this might be priming you for something. And we will come to this in a minute. Now, most of the cases of SUDEP, and this is probably telling us something, they are unwitnessed. The common scenario is someone found dead in bed or by the bed. And so witness SUDEP cases are relatively rare, but they are series, some series of over 20. The one thing they have in common is that there was a convulsive seizure. And if you're really into the literature, you would see that there was a study called Mortelius, which was published some years ago in The Lancet, that showed SUDEP, actually recorded SUDEP. And this was in telemetry units and pre-surgical. Most of these happened during the night where people had convulsions. So every single recorded SUDEP case seemed to have involved a convulsion. And there's quite a lot of circumstantial evidence for seizures if there's no witness or no record. Sort of you can actually predict that a seizure had happened. Like, for instance, beaten tongue, incontinence, secretions. And if, as I said, if it's witnessed, then you have a convulsive seizure. Now, there have been a number of discounted mechanisms. And for instance, if you read the literature in the late 70s, early 80s, they're talking about suffocation. But I've been involved for a number of years with investigating for the coroners sudden death and epilepsy. And there's only been one case where suffocation seemed to have been someone with SUDEP. There was some confusion. And actually the husband of the lady was charged with her murder, was not SUDEP. So every other case you can actually discount because there's no evidence for suffocation. I already mentioned the deleterious action of antiepileptic drugs, but this is not really fully supported. There's a number of issues. Some of you may remember some years ago there was an issue that lamotrigine was a risk factor for females with idiopathic generalized epilepsy for SUDEP. And of course this generated a lot of heat. When we looked at the data, basically what was happening is that valproate, which is the standard treatment for this type of epilepsy, is associated with teratogenicity. So a number of females were switched on drugs that were not as effective or didn't have valproate, and as a result of this, you know, it caused SUDEP, or seemed to have triggered SUDEP. Now, of course, the first thing you should have asked, what's the biological plausibility of something being killing females? And the difference is teratogenicity, you know, in an indirect way. So the drugs are probably, they could be part of the They could be part of the puzzle, but it's not a complete picture. So in terms of three major leading explanations nowadays, this could be caused by cardiac abnormalities, seizure-triggered cardiac arrhythmias. It could be irreversible cerebral shutdown after a seizure. We know that 99% of seizures are self-limited, and they seem to just stop. So if you have a release of something that would cause the seizure to stop, like endogenous opioids, you might actually get an overdose of this, and your breathing just goes down and you die. And this is probably one of the things that you see when you have a seizure. The one thing that tells you often is a seizure is a flattening of the EEG you see after. That is likely to be the release of opioids. And indeed, you know, one of the early signs of opioids overdose is a flat EEG. So you know, there's some circumstantial evidence. We could also have respiratory abnormalities for whatever reason. You know, they could be central apnea for some reason, could be driven by the release of something. They could sometimes neurogenic pulmonary edema. The most likely thing now is that it's probably a predisposition of things that happen. Have you I'm sure that your cardiology is very good, and you all know about sudden adult death, SAD. Does any one of you know what's the commonest comorbidity in SAD cases? This condition is overrepresented 28 times in some cohorts. What is it? Did I hear epilepsy? Yes. Now, one simple constatation, if you're a cardiologist and you come across this, you call it SAD. If this is in the neurological arena, you call it SUDEP. And maybe neurologists and cardiologists are not talking as often as we should. And I wrote some months ago, so last year I wrote an editorial in Neurology saying that cardiologists should think brain and neurologists should think heart, because there's likely to be some very similar things. And it could be that all these physiological storms are bringing forward what could have happened later. What happened, for instance, the predisposing factors that research have established could happen in SUDEP. Well, if you have a convulsion, there will be an increase in QT dispersion, and over time you may have cardiac microlesions. Good evidence for that. There are going to be autonomic features that will build up over time. Heart rate variability seems to go down. And again, you know, this is something that we know that from cardiac side, a low heart rate variability is a strong indicator of cardiac death, of cardiac resulting. So this all seem to be building up to say that SUDEP might well be a form of SAD in someone that has epilepsy. Anti-epileptic drugs could be part of the puzzle because they might be changing sympathetic tone and increase cardiac arrhythmias as carbamazepine or lacosamide does. We know that. And they might, of course, be intrinsic susceptibility. We know, for instance, that kids that have Brugada syndrome, which is a cardiac arrhythmia, low QT, they are more likely to have idiopathic epilepsy, and in their families, idiopathic epilepsy often runs. So both of them are channelopathies. So again, they could be a common predisposition, and where the convulsions are just bringing forward the risk. And then you have the precipitating factors. You know, you have a seizure, something might go wrong, you have a cardiac arrhythmia, there might be altered repolarization of the heart. This will lead to a decrease in the output, increases cardiac vulnerability, and the heart could cause the trigger. And this the next seizure could be something else. So this is why I don't think we will ever find a common mechanism. We might find a predominant mechanism for an individual person. And going on, you know, we have some respiratory failure that could be a precipitating factor. And for instance, that will lead to hypercapnia and hyperischemia. And this could be also precipitating factors. the metabolic changes that we see when people have a seizure, the autonomic features that will actually start as a result of this physiological storm that happened at the time of a seizure. And this may all get together and at one point will actually lead to the event. Now, convulsions are clearly the major risk. And in some series, 100% of people would have had convulsions. Nocturnal convulsion seems to be particularly at risk. So you will see what we're building here. The risk profile seems to be people having convulsions during the night. And if they're not with someone that could help them or stimulate them or get them awake, could be part of the problem. This would explain why most cases of SUDEP, like many cases of SAD, they happened at this time and they had no witnesses. Nocturnal seizures, there's a very interesting study from one of my PhD students that basically, if you look at most seizures and people with that had SUDEP, most of them had seizures during sleep. So that's very clear. And if you look at even at the timing of the seizure, most of them they happen when people were asleep in the early hours of the morning. So there is evidence that has been replicated and seen in many studies that nocturnal seizures increase the risk. Now, the high-risk groups, so intractable seizures, habitual nocturnal convulsions, asymptomatic etiology, and more than 3 seizures a year. And the more seizures you have, the higher the risk. To a point, if you have 1 seizure a month, your risk of this increases by about 90 times. If you have 1 nocturnal convulsion a month, that's 12 a year. That's not a benign condition. So in summary, I think it's fair to say that this is the most frequent cause of death directly related to epilepsy in chronic epilepsy. It's related to seizure control, and it seems to be a predisposition of factors. That some of them build over time, and some of them are then brought on by the event itself during this physiological storm. So it's a very important message that they might be multifactorial. There's been some discussion if they're genetic of ethnic or national differences. I don't think that we have an answer so far. We know, for instance, that some cardiac conditions seem to have a higher risk and they're more common in epilepsy, as I mentioned already. There might be a difference in the quality of care. You could argue if seizures are well controlled, the risk will be less. And if you have a place where the quality of care is low, you might have a higher risk of SUDEP. Just to remember this. There's an interesting discussion, and this requires more research. Is it less in children? It does happen in children, but it seems to be less. Now, we haven't had the studies to say that this is the same everywhere. People that are interested in SUDEP usually provide good care. And if a child has epilepsy, in many situations they will be sleeping with the mother. So if something they are attended, that might be bringing down the risk. So all the sort of things they need more research for us to understand, to put a puzzle together that will eventually lead to the prevention. So I'm just going to go through this. Primary prevention is people not to have epilepsy. But that's, is when cure comes to their fruition of their wishes, might be many years away. So at the moment, the thing to do in terms of primary prevention is to avoid convulsions. So we should attempt to control, stop the convulsions at the early time by optimizing treatment, by making sure people take the treatment. Actually, the commonest cause for uncontrolled epilepsy, pseudochronicity as I call it, is people not taking their tablets. It's actually shockingly high. And doctors often believe that once they told the patient they should take the medication, they assume that this happens. But that's actually, you could say to some extent, is the exception. Because you know, there have been studies after studies after studies that shows that people are not as good as we wish they are. And when someone tells that they don't take, doctors tend to be very authoritarian, tell them off. So it's very important that you try to take them, that you can get things out and then you can understand. And you will be surprised by the time you find that this is a problem. So there's been some discussion using beta blockers to avoid SUDEP, but it needs proper studies. Implanting a pacemaker defibrillator. There are trials in the US going on, some of them partly sponsored by Cure, looking at the use of SSRIs because that seems to increase saturation to decrease the risk of SUDEP. The other thing we have is, could telling people be, could it help prevent? We tell people this is the outcome. Most neurologists in the Western world, they have an ideological problem in discussing death in epilepsy. If you go to see the cardiologist, they say, if you don't follow my treatment, we'll drop dead. Neurologists have a problem. So maybe if we were more open about this, could we make differences? At the same time, we need to sort of try to be very sensitive, maybe disclose information at the right time. And we should really be person-centered. We should actually, the last thing, you have a little kid, developed epilepsy, and you tell the mother the first time after seizure when it's panic and try, oh, and by the way, little Mary could die. I think that's not the right moment. You need to find, what will usually happen is the mother will say, doctor, could my kid come to harm if she has another one? So you can introduce this in a more sensible way. But it's very important, because this can be a driver for better adherence, better compliance with the treatment, and this could be part of the prevention. So if it's a low-risk group, I think that we still should share the information at the first opportunity. When I wouldn't actually make them sign that anything, I just would say that this is a risk. Like, if you cross the street and you don't take care of the cars coming, something could happen. So you need to sort of say, but if it's a high-risk group, I think we need to use this to try and tell them at every opportunity why they should consider epilepsy surgery, why they should consider change of treatment. Of course, if the person knowing the risk, they don't want to do it, that's something different. But you have done your duty of informing and trying to discuss with them. And I think that I always use this as a weapon when I think compliance is a problem, which is very often the case. Particularly if people that live alone, they might forget, they might have other things. People forget to take the drugs when there's a change of routine. Weekends, holidays, big family events, big changing partners, partnering, breaking up, wedding, changing houses. That's the time when people forget to take the tablets. And this is the high-risk time. And you can see that quite a number of SUDEP cases in American university, teenagers that have SUDEP, there's a spike of them when people leave their home, they're scared of the mother who's giving them the tablets, they go to college, and they start living the life of students and don't take the tablets. And you see the 3-4 months, CUTE has a program in the state to make kids with epilepsy aware when they go away the importance of lifestyle and taking drugs. So, I think that decreasing premature mortality should be an aim of antiepileptic treatment. I think it's very important. And we should try to get outcomes. SUDEP is a major culprit for premature mortality. And we need to ask ourselves as the next research, what's the overlap with SADS and how we're going to work together with the cardiologists to try to sort it. Because at the moment, as I see it, it's two trains running in parallel. And if they were together, we could be taking much bigger loads in research. Because in cardiac illness gets more research than money than epilepsy. So I finish here. I hope I gave you an account of SUDEP, of the several aspects, the importance this is for practicing physicians, neurologists, that we need to keep this in mind. Because when we treat people, we should always try to make sure that they get not in harm. And this seems to be a big problem in this population. So thank you very much for listening. I hope I haven't bored you with all these details.
Thank you, Professor Ley Sander, for the insightful and most interesting presentation. We now open up the floor for questions and answers.